Every single year, 7 in 10 women experience preeclampsia, one of the leading causes of maternal death. The World Health Organization says the condition is caused by hypertension, resulting in multiple organ failure. This episode is not just for pregnant women, but for women of reproductive age and caregivers. Welcome. The program is Sound Health on Lagos Television. I am Olasumbo Mudukwe. We'll be right back.
Stunting is at about 40% or thereabout. Wasting at the national level, over 6 to 7%. If you do the maths, it's totaling over 3 million children, some cases in Nigeria. And like former statistics said, out of every 10 children, only 2 gets to be treated. So part of the question we'll be asking, what happens to the additional 8? Are they going to be left to be on their own, to die? How will impact on Nigeria's future, our GDP, and the rest of them, Nigeria? And the idea is, how do we get the legislators to, prioritize nutrition funding, nutrition, bills that would see to it that the Nigerian women and children have better nutrition. One of the main challenges with developing improve in the nutritional status of Nigerian women and children has always been adequate financing. It tops the list. Nigeria has strategies, has plans, but when it comes to financing these strategies and these plans, you find out that at times money is allocated, but when the time comes for release, it's really a challenge. And so
the State House of Assembly, under my leadership, is currently working along with the relevant stakeholders to come up with the state nutrition bill for sustainability and enforcement. This will solidify domestic financing, institutionalize accountability mechanism, and enforce compliance. For that, I and my clerk have formally signed up as nutrition ambassadors and advocate in Zamfara State. Despite all the effort made by both the executive and the legislative arms, as well as our partners working in the state, we still have some gaps and need to redouble our effort in areas like timely release of funds, effective supervision, inclusive engagement, continued advocacy, and sensitization, among others. I have the utmost belief that our shared commitment will yield a fruitful result.
Join us via Zoom to enlighten women, especially those of reproductive age, about preeclampsia is Dr. Chukwuemeka Odeigah, a consultant obstetrician and gynecologist with Latros Specialist Hospital. Welcome, Dr. Odeigah.
Yeah, good evening. Thanks for having me.
In recent times, we have had cases of pregnant women develop complications relating to preeclampsia before, during, and after birth. Is there a reason for this?
Okay, well, what preeclampsia is, it's actually a multisystemic disorder. That means it affects different organ systems within the woman, okay? Characterized by hypertension, that is high blood pressure, and proteinuria, that means protein, significant protein in the urine, okay, occurring after 20 weeks of pregnancy, okay, in a woman that was previously normotensive, that's meaning the blood pressure was normal before, and previously non-proteinuric, meaning that there was no protein in her urine before, okay. As I said, it's multisystemic, so it affects virtually every system of the body. But the commonest signs which the doctor can easily detect are the high blood pressure and the protein in the urine.
Recent statistics from the World Health Organization says preeclampsia is responsible for over 70,000 maternal deaths and 500,000 fetal deaths every single year. That's about 7 in 10 women. Why are we still recording this toll despite medical interventions and innovations?
Okay, firstly, preeclampsia and eclampsia. Eclampsia is a complication that arises from uncontrolled preeclampsia. Is a difficult condition to predict. Okay, a lot of research has gone into predicting women that would eventually develop preeclampsia, so that preventive measures can now be adopted. Given its huge burden, that is as a cause of maternal deaths and also perinatal deaths. However, a suitable screening tool has not been developed yet, okay? And a lot of the preventive strategies that have been put in place, some of them, the efficacy of some of those things are highly questionable, okay? And then when you now add things that are peculiar to our own environment, for instance, access to good antenatal care. A lot of women are still going to TBAs, traditional birth attendants, both for antenatal care and for delivery. So a lot of times, the condition can actually go unnoticed, undiagnosed, and then eventually, before they know what is happening, it leads to complications. By the time these complications set in, even in the best of centers, in the most equipped of centers, even in the presence of complications, maternal deaths, perinatal deaths can occur. So it's a combination of lack of adequate preventive measures, lack of proper screening, okay, and then also lack of good antenatal care, and even sometimes weakness as a result of the weakness in terms of the referral system to know when exactly to refer. So all these are all things that contribute to the high mortality rates noted with it.
Is there a difference between preeclampsia and eclampsia?
Okay, preeclampsia, as I said, is a occurrence of hypertension and protein in the urine occurring after 20 weeks in a woman that is previously normotensive and no protein in the urine. Okay. Now, eclampsia refers to the presence of convulsions, okay, seizures in a woman that is preeclamptic, that has preeclampsia, and it cannot be attributable to other causes. So meaning that it's not that this woman is epileptic before, for instance, or that she had head trauma before, okay? These seizures are as a result of the preeclampsia. Okay, so that's the difference between the two.
All right. Dr. Odeigah, in your response, you pointed out that patronage of traditional birth attendants hard to reach settings by some expectant mothers are one of the contributing factors for high mortality rate. I know government has not only incorporated these caregivers in the system, routine care for pregnant women, but also equipped and trained them. Why is there a problem? Is it upscaling, or they don't have the required tools? Is it also that some women present late at the facility?
Yeah, that also is also a possibility. Sometimes these expectant mothers do present late, okay, by which time complications have already set in, okay. But even when they do present early for antenatal care, sometimes these TBAs, I believe, may have some difficulty in actually recognizing the signs, okay, because probably they are not some of the routine things that we do during antenatal visits, that is in the hospital. You know, some of these things like routinely checking the blood pressure, you know, doing urinalysis to assess the urine, and then, you know, other investigations and examinations as necessary. They may not be doing all that, and that probably have to do with their training, okay? And also, you know, even in the primary healthcare setting, from my own little experience, I've seen certain times some reluctance in actually referring certain patients because they think probably it's something they can manage by themselves. Probably they are seeing high blood pressure and they feel that giving what do you call it, antihypertensives is the solution to the whole thing, you know. And then before they know what is happening, it has now progressed to the level of having complications, you know. So probably upscaling, probably better training, and earlier recognition or detection of this condition, and then earlier referral to secondary centers, and then in certain cases tertiary centers is the way to go.
Let's look at the role of antenatal care in preventing preeclampsia. Can the condition be prevented?
Yes. In terms of prevention, as I said, a lot of strategies have been employed in the past, and many of them have not actually been too successful in preventing preeclampsia. Some of them that have noticed some we've had some degree of success with is with the use of low dose aspirin in high risk patients, okay? And also calcium supplementation in patients that have low calcium levels even before pregnancy. And then these certain screening tools have some limited success, such as the use of uterine artery Doppler evaluation, which is done at the time of a routine second trimester scan, usually done around 18 to 20 weeks for the purpose of assessing fetal anomalies. Now, applying these tests to high-risk patients, for instance, first-timers, what I refer to as nulliparous women, or, for instance, women with multiple gestation, for instance, certain patients have had a previous history of preeclampsia, patients with chronic hypertension, patients are already hypertensive even before they got pregnant, okay? Patients who are diabetic, you know, and other medical conditions, even in pregnancy. So applying these tests, these interventions to this group of patients would be beneficial. Okay. Now, antenatal, so part of the antenatal, the aims of antenatal care is that initially when they come, there should be an individual risk assessment, okay, of the patient, okay, to classify, is this a patient a high-risk patient? Is this patient a low-risk patient? And if this patient is high-risk, what are those interventions, as I've mentioned, which could be applied to them, you know? So that is part of the usefulness of antenatal care, right? That initial assessment. And then even during the antenatal visits, as I said, certain things are being checked, which include the blood pressure and the whether there's any the urinalysis, so whether there's any protein or glucose or any other thing in the urine. So when these things, if they are noticed, okay, then that is not the kind of patient we should keep for in the primary healthcare setting, okay? They should be referred up, okay? The truth of the matter is that even before we conclude that the blood pressure is actually high, we need to do measurements at least 2 occasions, okay? Separate occasions. So if at the primary healthcare setting, you notice it once, that is the kind of patient you should refer immediately, okay? So that when they are getting to the referral center, if they carry out their own evaluation and find out that they can easily classify the patient as having preeclampsia, and then subsequent management can take place.
When is this condition likely to occur or experienced by a woman? Have you ever encountered a woman present preeclampsia at the point of delivery without any history of preeclampsia?
It's very, very possible. As I said, it usually occurs after 20 weeks of pregnancy, and it can be during the antenatal period. It could be during labor, that's intrapartum. It could be happening for the first time even after delivery, within the first 6 weeks of delivery. So it is possible, and as such, the healthcare provider should have a high index of suspicion.
Dr. Odeigah, could family history, genetics be a risk factor?
Yes, there's a role for family history. Okay, family history is a risk factor. Family history, either the mother or the female siblings and things like that. It's also a risk factor. So when we notice things like that, when they give us that kind of history, yes, those kind of patients we need to pay extra attention to.
A traditional birth attendant or skilled birth attendant cannot tell these signs you mentioned. When is referral required?
I would say that in the primary healthcare center, in the TBA, if you notice that the blood pressure is elevated, even on one occasion, I would advise you refer. If you notice there's urinalysis, you are getting protein, significant protein in the urine, I would advise you refer. Okay, don't keep this patient to yourself, because if intervention is necessary, a lot of that cannot be done in the primary health setting. Okay. The management, where in established cases of preeclampsia, there are certain things we'll notice that would prompt us to talk about delivery, immediate delivery, irrespective of the gestational age. Okay. So for instance, if the blood pressure is uncontrolled, despite being on several antihypertensives, okay, that is an indication for delivery. Okay. If this lady is having neurological symptoms, okay, she's having, for instance, she's seeing flashes of lights, she's having headache, things like that, or she's having seizures like eclampsia, okay, those are indications for immediate delivery. Okay. If she's from the tests that will be carried out, the purpose of the tests that are being carried out, I said is a multisystemic disorder, so it affects other systems. So if it's there's evidence of end organ damage, for instance, if the kidney function tests are showing abnormalities, then that is an indication for urgent delivery. Or if, for instance, the liver function tests are showing that there are issues, that's an indication for delivery. Or in terms of blood clotting, the blood clotting mechanisms are showing that there's problem there, then those are indications for delivery. If there's issue with the baby, maybe it's showing that the baby from serial scans is showing that the baby is not growing well, okay, what we refer to as intrauterine growth restriction, IUGR. Or we see that maybe the test for fetal well-being, which can only be carried out in probably secondary or tertiary centers, okay, are showing that the baby is not well, okay. Those are all indications for delivery, irrespective of the gestational age. So you see that most of these things, it will be difficult to do in a primary health setting. Okay, so preeclampsia, hypertensive disorders in general, I don't believe should be managed in the primary healthcare setting. If you notice that while you are evaluating the patient at whatever stage, you should refer.
Is there any negative impact on the fetus or child as a result of preeclampsia?
While I was talking about indications for urgent delivery, I mentioned that if, for instance, the baby is not growing well, okay, or that the test of fetal well-being are showing abnormalities. Of course, if the baby is not growing well, is growth restricted, that will have impact on the baby. The baby, there could be prenatal mortality, there could be prenatal morbidity, okay? And the test of well-being, if the baby is, the fetus is already compromised inside the womb, the baby could come out and experience birth asphyxia, okay, which will have long-term complications, the risk of cerebral palsy and whatnot. Okay, apart from that, for us, the obstetrician, the priority is the woman's life over the baby. So if you have severe preeclampsia or eclampsia, irrespective of the gestational age, you'll be talking of delivery. And at very premature or preterm stage of the pregnancy, that could also, prematurity could also have implications for the baby as well. You know, the risk of what is referred to as respiratory distress syndrome in the baby, the risk of something called necrotizing enterocolitis, which affects the intestines of the baby, something called intraventricular hemorrhage, which has to do with bleeding into the brain. So it has a lot of effects, you know, on the baby. But our priority still remains the woman's life.
As we wrap up now, what advice do you have for a pregnant woman? It is actually a three-part question, Dr. Odeigah. Women of reproductive age and caregivers.
Well, for a pregnant woman experiencing preeclampsia, urgent management in an appropriate setting should be the most important thing for you. Preeclampsia does not always carry a death sentence if it's diagnosed on time and the right management is instituted. A lot of times the outcome tends to be good. It is only usually when they present very late or complications are set in that the risk of mortality goes up so much. So that is what I would say to the pregnant woman. She needs to register in the right place for antenatal care. She also needs to be involved in decision making as well. For instance, if they do the blood pressure, even in the primary health center, most of them will be aware of what it is. She should ask, is it normal? My blood pressure, is it normal? Is it high? Even if they can't give her the exact values, they should be able to tell her, oh, madam, it's normal or it's high, okay? So in situations like that, she should probably insist, I would like to, maybe move to somewhere else where I can get more caregivers. Appropriate referral is very, very important. Very, very important, okay? Even in secondary level of care, that is the general hospitals, we should know when to even refer to tertiary centers. There are certain complications that could set in this condition that the general hospital will not, because of appropriate facilities and all that, will not be able to manage. Okay, if we are delivering at a very, very premature gestational age, the pediatric care, incubators, and all that may not be widely available. Okay, so we should know when to refer and refer early. Okay, if for instance the lady is developing clotting disorder, something called DIC, disseminated intravascular coagulopathy, it's not that kind of patient we should sit on. Okay, because probably getting blood products like fresh frozen plasma and things like that may be a challenge even in the secondary setting, secondary healthcare setting. Those are kind of patients we should refer. Okay, if a patient is having intractable seizures, she's having seizures and seizures, it could be that she's bleeding into her brain. Okay, we don't have in the secondary care setting, most times we don't have a neurosurgeon there. So that's not the kind of the patient we should keep, we should refer. So what I'm telling you, that appropriate referral is not only from the TBAs or the PACs, even in the secondary level of care, we should know when to refer. So that is my own take-home message to everybody.
All right, preeclampsia doesn't carry a death sentence if diagnosed early. Present early to the nearest health facility. Dr. Chukwuemeka Odeigah, consultant obstetrician and gynecologist, Lateral Specialist Hospital, thank you so much for your time.
You're welcome. Yeah.
Sound Health continues with trending health report from around the world. Please stay tuned. The program is still Sound Health on Lagos Television. Preeclampsia doesn't carry a death sentence if diagnosed early. If you or anyone you know is experiencing this condition, seek help early enough. Don't underestimate the role of antenatal care. To caregivers, initiate appropriate and swift referral to save a life, because a stitch in time saves 9. This is where we say thank you on today's episode of Sound Health. For comments and inquiries, or you have topics you'd like us to treat, please send SMS to 0035826603 or follow us on social media at Lagos Television, #Sound Health. A sound health is a sound mind. Make healthy living your choice.